Good afternoon, everyone. Louis DeCaro back here of Drive Time Biomechanics. It's about 4:30 on a Thursday afternoon right now, and I'm excited to bring you a case that I actually just walked out of the room with. I was wondering if there'd be a really interesting case today, and actually one popped in at the very end. So this is a very common case that I see all the time, which covers a lot of different mistakes that practitioners make and a lot of ails that patients have that they shouldn't have. So this is a typical presentation. This is a 50-year-old female who came in, and she has 3-4 years of chronic quote-unquote plantar fasciitis. She's been to other foot doctors, she's been to podorthists, she's gone to the store, she's bought orthotics. She had a pair of what she calls hard orthotics 20 years ago. She had a pair of soft orthotics from one of the podorthists, and then recently she had a pair of over-the-counter arch supports from a local podiatrist, for which she failed all of them. So this is a patient, 50-year-old, chronic plantar fasciitis, and she's failed so many iterations of orthotics. So she comes in and pretty much, even though she's sent for orthotics, she has the idea that orthotics are just terrible. So why do orthotics fail? And one of the reasons is going to be what we're going to see today and what we're going to hear about today. So this is a patient, we dug a little deeper and went for a history, and it turns out that she was diagnosed with a limb length discrepancy at a very young age. Now, most people have some form of limb length discrepancy. Usually it's functional, meaning that one side muscles have created an imbalance from left to right, which create a little bit of a limb length. And usually the pelvis or the spine or the feet will compensate for the very small amount, and usually it's not that big of a deal. Now, when I say that big of a deal, it actually is a big deal, because it's the reason why many people have unilateral problems in the knees and the hips and the back, as well as in the feet. But when I say not that big of a deal, meaning it's nothing huge to start. This patient, however, though, had a big enough limb length discrepancy, was really young, that it actually prompted someone to prescribe a lift for her. And the patient reports that when she was young, about 30 years ago, she wore the lift for a little while, and she felt okay with it, but she stopped wearing it because it was a pain to wear. She didn't enjoy wearing the lift, and she couldn't incorporate it into every shoe, and when she went barefoot it would be different, and so the lift became a big problem. Now, a little background on myself. About 16 years ago when I started practice, I used to add lifts right away when I saw people, because I would measure them, ASIS to medium malleolus, and I would try to make a determination, are they crooked or not? And I would throw a lift under there, and it usually turns out that people would not respond well to it. And the reason why is that limb length discrepancy is highly complicated. Anyone who's come to any of my lectures, I talk about the 50 variables that go into limb length discrepancy. So if you're just trying to throw a shim under one plane, you're usually going to get it wrong. And that's why I never recommend just taking a tape measure. So this patient came in. She hasn't worn a lift in a long time, but she now has this chronic plantar fasciitis. She keeps failing orthotics, and she's here to try to figure something new out. So what's the first thing I do? I look at my poster, of course, with my 6-foot types, and I have her stand up. And right away, what do I see? So the patient told me that she's shorter on the right side than the left side. So what do feet do? Feet are a major compensator for limb length discrepancy. A foot can actually pronate or collapse up to about close to 3/8 of an inch of correcting limb length discrepancy. And so what we're looking for when I have a patient stand and try to find out where they are on the poster is, do they have 2 different foot types? Now, of course, this is always a chicken to the egg problem, but many people who start out crooked, for whatever reason, their feet try to adapt. And so what I saw on the patient was that their left foot, remember that's the perceived long side, actually was collapsing into an EF foot. And the short side, the right side, was more of a C. So when you see a C foot stand, it's more as a higher arch. And when you see an E or an F, it looks like it's more collapsing and abducted out. So why does a foot collapse and abduct out? It's because that side is long, and so it's trying to collapse to try to bring it down. The body is always trying to even itself out. So I look at the hips prior to moving the feet. So the patient is standing in resting calcaneal stance position, meaning they're very relaxed position. I put my thumbs right on the ASIS, and I noticed that the right side on her is about a finger's width lower, and that's appreciable, right? But then I raised the left foot, which remember I said is collapsed and rotated out, to more of a subtalar neutral position to be more like the right foot. And what happens is that the limb length discrepancy gets not only worse, but the pelvis rotates posterior. And so what that tells you is that the foot is compensating, is bringing the body a little bit more in alignment, but still crooked. But if you take the foot out of the equation, the body is really twisted, where the left side is just rotated way back, and it's way higher than the right side, which means that probably this patient started with a very significant limb length discrepancy. So the point is that why has this person failed for orthotics for plantar fasciitis? And it's simple. And I asked her this. I said, has anyone ever looked at this when they were treating your plantar fasciitis with orthotics? And said, no. They said they made me spend all this money on all these orthotics, but never looked at anything else. And so the take-home message here is that the rest of the body also has an influence on the feet. You can't just jam the foot and make it do what you want to do with a functional orthotic without remembering that the rest of the body is going to revolt. And so if you're treating a limb length discrepancy, if you're treating two different foot types and you're putting them in perfect orthotics, but those foot types are different because they're trying to compensate for a limb length discrepancy, the body is going to revolt, and the body is not going to feel comfortable in the orthotic because the body is saying, what are you doing? I'm trying to collapse one foot to be shorter on that side, and you're stopping me, and something's going to go wrong. The knee's going to start hurting, the hip's going to start hurting, the back's going to start hurting. Or the orthotics, simply like with her, are going to feel very uncomfortable. Then they're going to give up on the orthotic, and the podiatrist, whoever's making the insert, is going to look like they don't know what they're doing when they make orthotics. So what did I do for her? So I said to her, listen, I'm not going to make you orthotics yet. That is the end game. But first, I'm going to send you to a good friend of mine who's a physical therapist who looks at the whole kinetic chain. And he looks at how much of this limb length discrepancy is functional, meaning how much of it is something that has kind of, with muscle or with twisting or with torquing, is actually morphed, and how much of it is structural. And what he believes, and what he's convinced me of in many years I've been working with him, is that most limb length discrepancy is mostly functional, 90% of it. And the good news is that 90% of that 90%, you actually can do really good physical therapy to get the patient back to even or close enough to even that you can make them a pair of orthotics that A, will benefit them, and B, will preserve whatever functional correction was made, whether that's through adjustment or muscle strengthening or whatever exercises that the PT has the patient do. So what I'll do is I'll send the patient to him. He'll work with the patient, figure out what's structural, what's functional, and what he'll do is send the patient back to me for a good pair of orthotics. Now, he may say, wow, we worked with her, she did great, but we still have about a 1/4 inch of structural limb length discrepancy. Well, then I'll add a lift onto the patient. But I will never add a lift, A, without an orthotic, and B, I won't add it until I know exactly that we've taken the functional out of the equation. Limb length discrepancy is extremely complicated. Limb length discrepancy is one of the reasons that people fail hard orthotics. Now, hard orthotics that's a redundant statement. An orthotic is supposed to be hard, it's supposed to be functional controlling. They will fail it when the body will revolt because it's trying to compensate and the orthotics aren't letting it. So these chronic plantar fasciitis patients that aren't getting better with anything, think about that the next time you look at them. Send them to a good physical therapist in the area. Don't just shim with a lift. Don't try to be a hero just by having them spend all this money on orthotics. Try this out. I really appreciate it, and I hope you guys have a good rest of your day. Thank you.